Good afternoon or good morning, depending on what part of the country you're in, and welcome. My name is David Memel, and I lead Cardinal Health's Physician Specialty Group Purchasing Organizations. Today, we're excited to share with you the insights from our research with rheumatologists across the country. This research is discussed in the recently released edition of Cardinal Health's Rheumatology Insights report. Before we begin, there are a few housekeeping items that I'd like to share with you. Number one is if you have questions during the webinar, please type them into the Q&A box and we will address them at the end of the session. And number two, please complete the 3-question survey that will appear at the end of today's webinar. Now, I would like to introduce our panelists. So next slide, please. Thank you. So first is Dr. Gordon Lamb, who is the Medical Director of Clinical Research at Arthritis and Osteoporosis Consultants of Carolinas. Dr. Lamb received his undergraduate degree from Princeton University and his medical degree from the Duke University School of Medicine, where he also completed his residency in internal medicine. Dr. Lamb completed his rheumatology fellowship at the Johns Hopkins University School of Medicine and is widely published in peer-reviewed journals and has lectured at national and international medical conferences. Our next panelist is Dr. Amar Maju, who is the Director of Clinical Research at Shores Rheumatology. Dr. Maju earned his medical degree and completed fellowship training in both geriatrics and rheumatology at Wayne State University School of Medicine and the Detroit Medical Center. Dr. Maju, as I mentioned, is Director of Research and has been involved in numerous clinical trials. He serves as the president of the Michigan Rheumatism Society and is on the board of directors of the Coalition of State Rheumatology Organizations. And our third panelist is Dr. Sonia Oskui, who is the Vice President of Biosimilars at Cardinal Health. Dr. Oskui is a healthcare executive and established thought leader with numerous publications, experience engaging with the FDA, and participation in industry organizations such as the Center for Biosimilars, where she is currently serving on the board of advisors. In addition to her training as a doctor of pharmacy, Dr. Oskui completed postgraduate residencies in clinical pharmacy and health system pharmacy leadership, is a board-certified medical affairs specialist, and a diplomat of the American Society of Health System Pharmacists Leadership Academy. So I'd like to set the stage for the topics the panel will be discussing by providing you with a few statistics about the rapidly changing rheumatology space. Number one is about 25% of America's adult population suffers from arthritis. Number two is that arthritis and other rheumatic conditions are a leading cause of work disability among US adults. Number three is that by 2030, 67 million patients will have rheumatic diseases. However, the number of full-time adult rheumatologists will be decreasing. It will go from about 5,600 to 4,200 over that period of time. So there's going to be a mismatch between the growth in number of patients and the decrease in number of rheumatologists. And then lastly, the global market for rheumatoid arthritis drugs is expected to reach $38 billion by 2027. As a company that works closely with rheumatologists, rheumatology practice managers, and pharmaceutical companies on rheumatologic therapies, Cardinal Health has seen firsthand the changes that are impacting the rheumatology field. And we wanted to better understand how providers in this space are responding. So to accomplish that goal, earlier this year, we launched a survey with 100 rheumatologists nationwide to explore the dynamics impacting their specialty and their patients, including areas such as biosimilars, health equity, and how to navigate the changing ecosystem. The rheumatologists surveyed were a mix of community-based and hospital-owned practices. And a copy of the Rheumatology Insights report is available for download from our website at the address that you see here. And I believe that's also going to be placed into the Q&A box or otherwise provided to you. So now I'm going to turn to the panel, and we're going to start with Dr. Lamb. So Gordon, rheumatology providers have navigated a lot of change over the past few years. Can you discuss some of the overarching findings of the report and how you've experienced this in your own practice?
Yeah, absolutely, David. Thank you so much. And before I begin, I just wanted to take a quick second to thank all of you who are online joining us today. I know that you're likely in the middle of a very busy day, so thank you so much for a little bit of your afternoon or morning. And then also, I wanted to just kind of set the background. This Rheumatology Insights, believe is now the third year that Cardinal Health has been doing this. I was involved. I was lucky and fortunate to be involved from the very beginning. And I have to say, the premise was simple, simply to get a finger on the pulse of what's going on in rheumatology by simply putting forth a survey and getting people's responses. But I think what was at least surprising from my standpoint, was to see, number one, how prescient Cardinal Health was. The topics that they asked were really ahead of the time. Everything from biosimilars, which Dr. Osquay will be talking about later. They started asking about this from the very beginning. Things like the changing workforce dynamics in rheumatology, changes about plasticity and changes, and even before COVID-19 hit. But the other thing that's been really surprising to me is how impactful the results of this survey have been. Not only how much it has really illuminated and elucidated the current thought process in rheumatology, but now how it's being picked up across all of rheumatology. I don't know if you folks have seen, but this latest Rheumatology Insights really got picked up across the wire by places like Helio, and it was being a lot of the reprints were out in the biosimilar space because a lot of what was being reported or what has been reported through Cardinal Health is now really coming to fruition. So David, really kudos to you and your team for putting this forth, and I really hope that it continues to be impactful. So the section that I was charged with kind of analyzing and discussing is navigating a changing industry. So if we could advance to the next slide. I don't have to tell all of us that the past 3 years now have just been a whirlwind. I don't think any of us could have ever foreseen COVID-19, the direct and the indirect impacts that it has really had on our practices. I remember having discussions with many of you about how we seemingly overnight had to stand up telehealth. We had to adjust to changing workforce dynamics, concerns of health, personal health. And to this day, COVID-19 continues to impact rheumatology patients and practices. But it's a never-ending, continuously evolving story. Now with the relaxing of COVID-19 restrictions, we're seeing a little bit of an uptick in COVID-19 cases. We're seeing evolution of the variants, changes and evolutions of vaccines and vaccine responses. But we're also seeing a lot of fatigue with COVID-19 and how that can affect the interaction that we have in the office. In the survey, nearly 40% of patients, of rheumatologists said that the relaxing of COVID-19 restrictions has really impacted the health of their patients, both the physical health as well as the mental health. And in fact, the majority of respondents said that the relaxing of COVID-19 restrictions had a negative impact on the health of patients with rheumatic disorders. Next slide, please. And in addition, the mental health, not surprisingly, is worse. When we look at the reasons why mental health can be worse in patients, first and foremost comes to just the stress, the anxiety of the pandemic itself. But now that we're 3 years into it, I think that the fatigue has overtaken a lot of that initial stress and anxiety. But I think the mental health continues to be an issue. We have unearthed other concomitant or underlying depression and anxiety. The isolation, the impact is still the same. And now one of the hottest topics in rheumatology and medicine is the effects of long COVID and some of the mental and cognitive deficits and impact that it can have on that. The majority of patients thought that the mental health is either worse than or the same as before. And surprisingly, at least surprising for me, was when the question was asked, where are you directing care, the mental health care for your patients? 21% of respondents said that they treat mental health issues by themselves or in their practice. And the reason why this was surprising for me is because historically, rheumatologists, and myself included, would refer out patients to, say, psychiatry, psychology, primary care to seek their treatment. And even before the pandemic, we knew that the stress on our psychiatry and psychology colleagues was already great. Wait lists were several months long. In fact, where I am in North Carolina, in the Charlotte area, a referral to a psychiatrist was often 8 months long. And I think that just by sheer necessity and desperation, we started managing mental health issues of our patients ourselves, which was a little bit outside of the norm. And it's kind of has forced us to adapt and evolve, which actually is sort of the concept of the overarching principle of this section, which is how flexible rheumatologists are and how resilient we have been in addressing the impact of COVID-19. So next slide, please. So as part of this, we've seen supply chain disruptions. At first, it was due to COVID-19, but then just in real world, real life, we've seen supply chain disruptions throughout every industry, whether it be the housing industry, the automotive industry, et cetera. And in our respondents, 85% of participating respondents said that supply chain disruption have impacted treatment decisions, and they have adapted with several strategies. So number one, and I'm going to kind of go from the top right, is delaying therapy. Now, that's not ideal, but if we don't have medicines, then oftentimes we have no choice, which is to delay therapy. We also saw treatment interruptions and a lot of loss to follow-up situations with COVID-19. Next, I'm going to go to the bottom left, which is switching patients to a different medication. So this is called non-medical substitution. And non-medical substitution is changing a medicine purely for either financial or physical supply chain disruption reasons, not for a medical reason. That's also not considered to be ideal. But again, in dire situations, we're sometimes left to dire choices. And then last was substitutions for medicines. And this could be substitutions of other medicines, like non-medical substitutions, or substitutions of other therapies. So for example, physical therapy, referring them to orthopedic surgery, or other modalities like topical therapies, et cetera. So I think what this represents is how plastic, resilient, and flexible rheumatologists have been because of this context that we're in. But I think this also represents the greater scenario of all of medicine. And next slide, please. So before Dr. Maju talks about health inequities, the one thing that I'll mention is that the supply chain disruptions that we've seen are still present, whether it be shortages with Actemra, reclass for a little while, Solumedrol, lidocaine, Benadryl. I'm sure that many of you have had others. We don't know when the end will come. We hope that it will get better. But I think the one constant, though, is how flexible and resilient rheumatologists have been. What will be interesting, though, is to see what the future will bring and how we respond henceforth. There are so many other pressures on us, whether it be workforce shortages and how we respond to that. Recently, Dr. Maju and I just returned from our annual International American College of Rheumatology meeting, and workforce shortage was a big discussion. I think we're all sort of bracing for the advent of biosimilars, and once they really hit next year, and Dr. Osque will be talking about that in just a little bit as well. But what will be fascinating is to see how we continually respond and change to every single one of the challenges that we face. So David, with that, let me turn it back over to you. I'll be happy to answer any questions now, or if we want to take questions at the end, I'm happy to facilitate that as well.
Yes, thank you, Gordon. That was very interesting, and we will hold questions till the end. And so, Amar, I'm going to turn to you now. In addition to what Gordon just addressed, one of the other major challenges we face is health inequities across the healthcare landscape, including in rheumatology. Can you walk us through what the survey found related to this topic, please?
Absolutely, I'll try my best. Again, thank you to everybody at Cardinal Health for putting this together. And David, thank you for that introduction. Gordon, thank you for that eloquent summary of the findings. And thank you again. I want to reiterate Dr. Lamb's welcoming remarks as well. And thank you all for taking time out of your busy schedules in something I hope you find very useful. So, on a personal note, I was asked to participate in the section dealing with healthcare inequities. And I have to say that I found this to be um, both personally beneficial and educational for myself, uh, being participating in the development and review of the questions and then going over the findings. And I found myself researching and questioning more and more, which I think may be one of the pearls to take away from today's discussion, is that there's this opportunity to always self-educate and think about things and educate others. And it's really trying to put yourself in somebody else's shoes. And I think that's one of the key messages or takeaways. So the results were interesting, and they tell a very optimistic story. And I think the first bit of optimism is that when the respondents were asked whether or not health inequities existed, there was an acknowledgement that yes, health inequities do exist, and you can see that summarized here. And really, on the two parts of this graph, on the left is the question pertaining to healthcare inequities existing throughout healthcare. And then on the right is specific to rheumatology itself. And so, number one, there was an acknowledgement that health inequities exist, which I think is very important because that's really the first step to addressing a situation or a problem is acknowledging that it does exist. The interesting part here, and I think I liken this to using those Snapchat filters. Maybe when we take a picture or a selfie of ourselves in rheumatology, maybe we look at ourselves with a little bit the lens of those filters. So if you look, overwhelmingly, the respondents agreed that healthcare inequities exist in medicine in general. But when we talk about rheumatology, you can see that the answers sort of shifted away from strongly agree, kind of centered in the middle with agree and neither agree or disagree. So, you can look at it two ways, that there is an acknowledgement that inequities exist, and perhaps we look at ourselves with a little bit of optimistic lenses because we know that healthcare inequities exist in rheumatology, and this is probably best studied and described in diseases such as lupus. And we know that, for example, it's a very easy example in lupus, this disease disproportionately affects women, women of color, in terms of its prevalence and also its severity. And these are the same populations that have the greatest challenges in accessing healthcare. So again, these are the findings. So next slide. Now, some additional interesting findings here that when respondents were asked to finish the question, healthcare inequities within rheumatologists can lead to differences in, you can see that the majority agree that access to care and patient outcomes can be affected by healthcare inequities. Not listed, but 86% of respondents also agree that healthcare inequities can affect the time to diagnosis for the diseases that we treat. Although only 40% of respondents felt that this could affect disability, which I thought was quite interesting and sort of a paradox, because we all are taught and probably know firsthand that in the diseases that we treat, early identification and intervention is key to preventing disability. So this is a very interesting find, and I'm not sure exactly why that was the way it was, and perhaps maybe a little bit beyond the scope of the research that was done here, but certainly an interesting find. This was also interesting. If you look at the circle graphs on the right, you can see that 97% of respondents thought that rheumatology as a field is attracting candidates of either many candidates or some candidates of diverse backgrounds. And so, again, I guess that really depends on your idea of diversity. If, for example, you worked at a clinic and you saw our panel here, looking at our names and perhaps variation in skin color, you would think that this is a very diverse field. But really, and I think this is well grounded, and I would invite you to read. There was a paper in A&R. It was a online forum conducted by the Women's Hospital, Brigham and Women's Hospital. It was entitled the Diversity in Rheumatology Research Workforce, and the definition that they use really put into proper context what diversity is, and it's really your representation in medicine compared to your representation in the general population. And so there is significant data to support that certain groups are considered underrepresented in medicine, and this would include African Americans, Native Americans, and Hispanics. So again, I think maybe depending on what your definition of diversity is, and perhaps a lot of respondents were thinking of the fact that a lot of women are now in the rheumatology space, which is great, but there's still a lot of work to be done. And why is that important? I think that's important because it really can affect patient outcomes because of racial concordance. Patients may feel a little bit more comfortable being able to connect with their provider on some level. So that's just things to consider, and maybe as we talk about the next session, next slide, please. In terms of how we can take action. And so this again was a optimistic finding that rheumatologists recognize that actions need to be taken to kind of move that needle. And you can see on the left what were some of the resources that they ranked high in terms of addressing inequities and in terms of educating. So and tools that are available. Health resources and share information with patients, community-based, educate themselves on health inequities, and I think that's what we're all kind of doing. Ensure that office staff are sensitive to patient backgrounds, and I think that's very important as well. So perhaps having some sort of policies in place or staff meetings and so forth. Provide appropriate patient educational material in different languages, including diversity amongst your staff, and educating basically your staff and one another about these inequities that do exist and what we can do about it and why it's important. In terms of what the respondents themselves had participated in to educate themselves, you can see the responses here. Online resources, literature research, and talking with colleagues, as well as attending seminars. So again, My experience, even participating in this project itself, was very beneficial in many ways. And I think that's something that we can all do, is to just keep our eyes and ears open, and educate ourselves. Um, I think that's key. Obviously, we can't change our names and the color of our skin, but we can certainly do our best to be able to connect with our patients. And there's so many things that we can do to be able to make that connection. I heard of a physician that is of Far East Asian background and had a slight accent, but because she was living in New York, she learned how to speak Spanish to be able to connect with her patients. So maybe most of us are not able to do that, but we can certainly take small steps to improve the experiences that our patients have. Next slide. And with that, I will pass the baton.
Thank you, Amar. I think the last comment you made is really important about what can be done by each person who is practicing rheumatology. So now I'm going to turn to Sonia. And Sonia, one of the areas that is a very hot topic as well is biosimilars. And there is the new wave of the highly anticipated Humira biosimilars that are expected to hit the market next year. So can you share with us some of the findings about biosimilars, please?
Absolutely. Thank you, David, and fantastic overview, Gordon and Amar. I like to think biosimilars actually ties into both the topics already presented already, especially when we look at supply restraint and challenges from events like COVID-19, which hopefully we don't have anything else like that happen in our lifetimes, but also health equity and access to treatments. And so when we think about the promise of biosimilars, it's on those twin pillars of affordability and accessibility. So I'm very excited to talk about all that's going on in the biosimilar space, highlighting the key findings from this report. Before we go into the findings that we're going to highlight, just to level set on where we are in the US, we now have 39 FDA-approved biosimilars, 24 of them are on the market. Thus far, still vast majority of activity has been in the oncology space. So at least 18 of the biosimilars on the market have oncology indications. However, we've had our infliximab biosimilar since 2016, and we have a few of them now. We have rituximab biosimilars that have rheumatoid arthritis indications. And looking ahead, we're going to see growth, particularly in the immunology space, with biosimilars coming to market for new innovator products. So I really believe we're in this pivotal time for biosimilar activity in the US, specifically for rheumatology. Another key reason is for exactly what David shared. 2023, we've been talking about 2023 since the beginning of my focus in biosimilars 7 years ago. So this is a big monumental year. Of course, it's because of adalimumab. We'll be facing competition, and not just by 1 or 2 biosimilars, but there's already 7 FDA-approved adalimumab biosimilars waiting to launch in 2023, at least 3 more in development. So this is a huge, huge pharmaceutical event. As a reminder, adalimumab is the top-selling drug, not only in the world, but of all time. And it wasn't until last year that it lost its #1 spot, and it was because of the COVID-19 vaccine. So just to show the significance of this in that perspective, it's a reason why we really want to ask these questions and gather more market insights and perspectives from rheumatologists on how this market's going to play out, how are they going to be evaluated, how are these products going to be adopted, and so forth. So with that, we can go to the next slide. One of the great, I would say, advantages of working in a network like Cardinal Health is that we constantly are gathering perspectives and insights in rheumatology. And so we've been doing market research year after year. And what is nice to see is that we could ask the same questions, and this way we could see trends and try to understand what's influencing the changes and so forth. So first and foremost, one of the key questions or key question we ask is just familiarity with biosimilars. And if we look at the left-hand side, we see significant growth in just familiarity since 2020 to 2022, which now this year, over 75% of rheumatologists said they're very familiar with biosimilars. When we look at the right-hand side, We asked about comfort with prescribing biosimilars, and we know that familiarity doesn't always grow with comfort. You could have be very familiar but not comfortable, but we also saw significant growth in comfort in prescribing biosimilars to patients. And when we think about, well, what is the driver behind that, there's multiple reasons for it. First and foremost, just time and exposure. Like I said, the first infliximab biosimilar was available since 2016. So having more of these products launch over time just gives an opportunity to evaluate and understand these products more. What I'll also highlight is earlier this year, we released a Cardinal Health Biosimilars report where we took a deep dive in biosimilars activity across all the therapeutic areas that have biosimilars. And what we also looked at is all the different influencers of adoption and summarized key ones. And one of the key ones is the managed care landscape. And you can find fairly strong correlation between payer coverage and movement from policy standpoint of payer policies and growth in biosimilar adoption, particularly in rheumatology. So today infliximab biosimilars have now exceeded 40% market share, which is a big growth since even 2020, where it was roughly around 15%. And you see that growth correlating to greater payer coverage as well. So a lot of different drivers behind just the familiarity and what I would believe comfort associated with these products. What I would also recommend, just as everybody's noted here, there's a lot more interesting data in the Rheumatology Insights report. So if you haven't checked it out yet, I do recommend it because we get into a little bit more color behind some of these questions and still some additional concerns. So one of the points that's really interesting to me, at least, despite the growth in familiarity and comfort, we asked, again, just like we did in 2020, rheumatologists, what are your top concerns with prescribing biosimilars? And both times, both in 2020 and this recent year, efficacy was actually still the top concern. So it's very interesting to see that perspective ahead of, again, a lot more biosimilars coming to market with rheumatologic indications. Go to the next slide. So naturally, we are taking a deeper dive on adalimumab specifically, just to understand how these products are going to be managed and evaluated. And this question that we're showing here is really around comfort with prescribing adalimumab biosimilar to your patients once they're available. So vast majority are at least somewhat comfortable with prescribing a biosimilar, which is very interesting. And there's always, you always want to go a layer deeper to understand, okay, well, in which scenarios or which products. So there's a lot more market research that is included in the Rheumatology Insights report, and we have additional activity going on too that we will be publishing early next year as well. But in the Rheumatology Insights report, we did ask, well, if you have this comfort prescribing biosimilars or adalimumab biosimilars to your patients once available, but for which patients would you feel most comfortable, or which patients would you likely use the biosimilar for? And the top answer was existing patients for whom payers had mandated the biosimilar. And following that was new patients. So this kind of goes along with a lot of market research we've done so far, where even whenever we're in a new therapeutic category with biosimilars, you tend to see heightened comfort with starting new patients on a biosimilar versus those that have been on one, stable, and then transitioning to a biosimilar. And this seemed to reflect that as well. It's really new patients, but if the managed care landscape or the payer is mandating a switch, then that would be a scenario where it would occur as well. Go to the next slide. So this is the last key question that we're highlighting on this webinar, but ultimately we asked what would be key decision criteria for utilizing an adalimumab biosimilar. And I actually find these findings very interesting for multiple reasons. We look at the top answer was patient out-of-pocket costs, which to me is fantastic because that is the promise of biosimilars. It needs to reach the patient. What would be the incentive to want to use a biosimilar, especially if you're already on treatment, stable, et cetera? It really does need to reach the patient. So we know the innovator product on the market, the originator, has strong patient support services, wraparound services, copay programs, et cetera. So when you look at these biosimilars that are going to come to market, there is essentially an expectation that the patient experience should be at least at that level of what they're used to with the originator product. So I think that is a signal to the life science companies who are launching these products to market, working on their strategies to make sure that they could serve patients in the most efficient and effective manner. After patient out-of-pocket cost, the second highest key decision criteria was clinical and/or real-world evidence studies. This one is probably one of my favorite answers, because we could say there's actually a lot of that. This is not a space where the US is in the lead by any means. The European Union has had biosimilars since 2018. Four adalimumab biosimilars were launched in 2018. There's adalimumab biosimilars in Canada. There's actually a wealth of data and real world studies and evidence associated with these products, which is fantastic because we can't say the same for ophthalmology, for example, or some of these other therapeutic areas. So the data and evidence is there, and it's really on us to leverage it and apply it to building clinical confidence with these agents. And I'll say, even in this past year, the conversation went from, oh, we want to see data and real world evidence, from being on the originator to switching to the biosimilar. And then questions started to come up. Well, now we want to see a biosimilar to biosimilar. We don't see a lot of data on that. And that was the desire, which is pretty natural. When you look at an increasing pipeline of biosimilars for the same originator product, there's a likely scenario that you could be switching from biosimilar to biosimilar at some point. So there are recent meta-analyses published that are fantastic that looked at exactly those scenarios. And scientifically, what I would say we would expect, that safety and efficacy and outcomes were just as equal to the originator product, and no major concerns were identified. So more and more data of that is coming, and some of those multiple switching scenarios, and we see a lot of that. But again, not a place that the US is in the lead when it comes to biosimilar experiences, and there's good data that we could do, data sharing, knowledge sharing, and et cetera. The third top answer here was pharmacy benefit managers and payer coverage. So we see a healthy combination of clinical and economic when it comes to considerations with these biosimilars, specifically adalimumab. And I feel like it's almost breaking news, but even just this morning, one of the major PBMs shared that they are planning to cover the originator and 3 biosimilars, adalimumab biosimilars, at parity status, which is actually big news. So that was almost shocking to see that they put it out there. But my personal opinion is that there's almost a social demand and need to cover these agents. This is a big opportunity for cost savings, not only patients, providers, but the overall US healthcare system. So we're likely going to see more decisions like that being made and announced. I will say, I do believe that the years 2024 into even 2025 will likely be the most significant for having the impact of adalimumab biosimilars. We have one adalimumab biosimilar launching in January of 2023, and then you have the big group of them coming in July. So by the time formulary decisions are made on health plans, it could be into 2024, and you see the adoption and the impact of that. So very, very exciting activity coming up, highly anticipated year for multiple reasons. And with that, I'll just say that this is a big year for adalimumab, but you look at the pipeline, there's products like Stelara, Actemra, much more, I would say, innovator strong products that are anticipating biosimilar competition. And the desire to see healthy competition in the market for biologics is there, and it's all around bringing increased competition, which would then lower costs and enhance patient access to these critical treatments. So with that, David, I'll turn it back over to you.
All right, thank you, Sonia. And it really is it's an amazing area. I've been involved in the biosimilars space since 2013, and it's just fascinating to see how it's evolved over that time. So, and in addition to Sonia, Gordon, Amar, thank you very much for the overviews you provided. And before we move into the Q&A, I'd like to remind the audience to please put your questions into the Q&A box. And I'd also like to take a moment to highlight that in addition to your colleagues, to patient advocates, professional associations, and other sources of support, Cardinal Health also can help you navigate the challenges and the changes that we've discussed today. Cornerstone Rheumatology GPO is our group purchasing organization that is focused exclusively on rheumatology practices. We not only provide access to a strong portfolio of specialty drugs for treating patients with rheumatic diseases, but we also provide a suite of innovative solutions and services and networking and educational opportunities that can help your practices be successful in this dynamic environment. And lastly, I'd like to point out that for the past 10 years or so and continuing today, we have had a unique partnership with Norm Ventures that helps support education and advocacy programming for the National Organization of Rheumatology Management members. So with that, I'd like to move to the Q&A. And the first question is to anybody who wants to answer this. Why do you think patient mental health is worse now than when the pandemic first began?
Yeah, I'll be happy to answer that, David. So we kind of touched on that a little bit in my brief section. Number one was the stress and anxiety of the pandemic itself, the unknown. Then that led to a cascade of other downstream effects, interruption of therapy, worsening of the underlying rheumatic disease because of it. There were issues with costs and supply chain disruptions. There were the collateral effects on personal and social aspects of health with workplace interruptions, school disruptions, etc. And then now there's the unknown and then of course the long COVID effects, which we're seeing having a significant effect on the emotional and mental well-being of patients. Everything from fatigue, brain fog, difficulty with cognition, memory, which are absolutely real. In fact, that's actually one of the big topics and initiatives in rheumatology now. We're starting on a new initiative with the Cleveland Clinic to further evaluate this, and there was a lot of discussion. We think that rheumatologists are in a very good position to address these issues of long COVID, just because with a lot of the analogies of chronic fatigue syndrome and myalgia, encephalitis, encephalopathy, chronic fatigue syndrome, fibromyalgia, etc. So I think taken together, it all kind of led to worsenings of mental health. And then on top of that, the whole issues of the ongoing unknown and where not only the next year will be, but the next week or the next month. So this is one of these things where we've learned to really rely on each other, both our colleagues and as well as our patients and patients among themselves to get through it. I can only imagine where it may be, but I'm kind of hoping that things will continue to slowly get better. But in this setting, with how very unique the past 3 years have been, we just don't know.
Yeah, thank you. Amar, you want to add something to that, it looks like?
Sure. Yeah. I totally, I think that this topic is so complex and probably, there's so many things contributing to that. But I noticed with my patients, the social isolation, a lot of my older patients that couldn't see their grandkids and, quite frankly said, they didn't care because they didn't know how longer they had to live. So they would rather take their chances getting COVID instead of being, locked up in their homes. So I think the social isolation, especially for those that were single and didn't have people, and that could be very young or the elderly. And then I think also the growing mistrust in government and even our healthcare institutions, I think has compounded a lot of those issues.
Okay, thank you. I'd like to start with you, Amar, for the next question. And that question is, are health inequities more prevalent in rheumatology than other specialties?
That is a good question. Certainly our survey respondents thought to imply, at least based on their response, that it was a little less perhaps prevalent in rheumatology, but to my knowledge, there is no sort of cross-specialty study that could support or refute that it exists in one area more than another. I can say that certainly within our field it does exist, and so keeping within our lane, it's there and it's there for us to address.
Anybody else want to add to that?
Well, I just wanted to say that the whole discussions about diversity, equality, inclusion is one of the hottest topics in medicine right now. There are a number of work groups and workshops that being done and planned, not just in healthcare, like direct clinical care, but also in improving these aspects in clinical research, which drives healthcare, medical education, to educate the future generations of providers who will be taking care of these patients. And what I'm starting to learn, because this is an educational process for me as well, is the many different aspects. It's not just necessarily about race. It could be about ethnicity, age. It could be about educational status. It could be about geographical deserts. It could be other aspects of life that then relate to health. So for example, if there is a food desert, if there is a literacy desert out there, and these deserts can even occur in large metropolitan areas. So it's just absolutely fascinating about the effects of these inequities and how improving them can have more universal effects as well. So to answer those specifically, the question is, are inequities greater or less in rheumatology versus elsewhere? I don't know, but what I do know is that we serve a very unique population in how broad it is. In rheumatology, we see people from kids all the way to older adults. It's not just limited to a particular patient population. It's not just limited to one specific organ system. So if anything, I would think that the effects of these discussions and inequalities would probably be a little bit more pronounced in rheumatology.
Okay, and a follow-on question to that then is what can rheumatologists and practice managers do to learn more about the health inequities? That's to anyone who wants to answer.
I think there's a variety of resources and tools, and as Gordon mentioned, it's a hot topic. And we're just coming back from the ACR, and there was sessions on healthcare inequities. And to Gordon's point, I think it goes beyond race. Educational level will certainly affect your patient's ability to comply, or as you mentioned, access to food. It's great to talk to people about anti-inflammatory diets and organic foods, but if they can't afford it, that's maybe not realistic. So I think any type of our national conferences, local conferences that offers education, I think looking into these things, looking into our peer-reviewed journals. There's numerous articles and publications that are coming out. I'm the president of my state society, so I think it's long overdue. We have not had something to address, this topic on our previous state society meeting. So I'm going to make it a priority to make this one of the topics at this year's meeting. And I think others that are listening in that are involved in their state society or any type of education of residents and fellows should look into incorporating these things into the curriculum.
That's really actually great ideas. Thank you. I'd like to shift to some questions that have come in about biosimilars now. So let me start with you, Sonia. The first one is why do you think that rheumatologists are more familiar and more comfortable with biosimilars now than they were just 2 years ago?
Sure, and I spoke to that a little bit earlier, and I feel silly talking about why rheumatologists feel more comfortable when there's 2 rheumatologists here on the panel. So I don't want to speak for you all. Definitely want your perspectives, but based on our market research and what we've seen in the market, we really could correlate it to increased exposure, increased experience, more products coming to market that are becoming options to evaluate and adopt in rheumatology. Like I mentioned, the increased utilization and market share growth for these agents are really in parallel to greater payer coverage associated with them as well. So we know there's these market factors. even ACR guidelines or position statement has been updated over the past few years, where it's, I would consider it more supportive, for biosimilars versus the initial one that was put out many years ago. So we're seeing growth in activity and perspectives and support for these agents in the rheumatology space. And quite frankly, increased familiarity is probably also attributed to what's about to come. It's not like something we can avoid or just hide or not talk about. We know that we have a big wave of rheumatologic biosimilars coming to market. So it's almost in preparation of making sure that you have your plan and strategy to provide optimal patient cares and how you're going to incorporate it into treatment plans. That's also a big driver. But would love to hear from the others.
Well, actually, I'd like to thank you. So I want to put a little bit of a spin on this for Gordon and Amar. How much of this do you think is a reflection of patients becoming more knowledgeable about biosimilars?
So I think it's a combination of things. So number one, the reason why rheumatologists are becoming increasingly familiar with it is because, well, number one, it's coming on us. It's the whole concept is coming. But number two is that the overarching principle is incontrovertible. One of our biggest frustrations in healthcare is access, and that if we want to have a patient start a medicine that we think is appropriate for them, is to then not be able to prescribe it because of cost or access issues. So the whole concept of biosimilars is to lower the cost of these medications so that more people can have access to these revolutionary, life-changing medicines. I don't think anyone would disagree with that. But I think one of the interesting things, though, and Sonia, you had mentioned this in some of your data, was that the first reason why, I remember exactly what the wording was, why this was coming or people agreed or why we're on board was, number one was because of payer mandate or the situations when it would be used was payer mandate. And the second one was starting new patients. And the reason why I found this fascinating is because when biosimilars first came about, first in discussion several years ago, there was a lot of concern amongst rheumatologists about non-medical switching. That is switching patients from one medicine to another for purely financial reasons. And that wasn't right. If someone was doing well on a medicine, they should continue it. But that was the number one reason scenario where they would switch. Then number two, which is starting a new patient, absolutely. I think that's absolutely valid. But I think what that speaks more to is autonomy and provider autonomy of what medicine they should be on versus what medicine they're forced to switch patients on. So one of the things that I think we should really follow up on, Sonia and David, and then Amy, is looking at seeing if providers are noticing things like nocebo effects, perceived decreased efficacy or adverse events, whether they're real or not, because that is going to be strictly tied to perceptions of mandated biosimilar switches, both by patients and the providers.
Which I think is a great point, because sometimes we see studies and it's not like any rheumatologic originator product that's used, it's always going to have 100% success rate, right? So is the conversion, is it really the switch to the biosimilar that may not have been successful, or was that treatment not on the right path anyway? So there's a lot of different considerations in evaluating that. And I just want to say the comment around non-medical switching is such a good one. And I'll say it's almost become like a controversial statement in the world of biosimilars, because do we consider, and these are different agents, I get the comparison I'm about to make, but would you consider going from a brand to a generic, a non-medical switch? And so kind of one of those things, it's the same treatment. So when you use even the terminology non-medical switch, is there a perception that I'm getting something else even though something was working? So that's becoming even a topic of debate across different therapeutic areas, which is so interesting. And I agree, Gordon, it'll be fantastic to dig into kind of the nocebo, the perceptions of this space.
Yeah, and actually one thing that we should also follow up on is the perception of autonomy and breaches of autonomy amongst providers with the biosimilars and mandates of switching.
Okay. Amar, anything you want to add?
Yeah, just to kind of comment, maybe hopefully add something new. I think we've all become more familiar and comfortable with the notion of biosimilars, and a lot of it is our own personal experience, but also maybe European experience where they're been using biosimilars and switching patients and so forth. But really, the concern is, it's kind of the WIFM, what's in it for me, but really what's in it for the patient. Because, for a lot of us, it's why are we switching if the patient isn't realizing any additional cost savings, or they're not getting a reduction on their premiums, they're not getting a check back at the end of the, at the end of the month, say, hey, your premium went down, their out-of-pocket cost is the same. So why create this inconvenience or angst amongst patients? And originally, when they first rolled out, there was a lot of uncertainty on the patient's part. I have to say the insurance companies, PBMs, and the manufacturers didn't do a lot of the education direct to the patient. They left it up to the providers, which was additional burden on our offices, and we were just a middleman.
Yep, good points. So with that, I would like to thank our panelists and those of you who attended and provided questions for the panelists. This is a reminder, please, to take the survey at the end, and also to visit the web address that you were provided to get a copy of the report, and lastly, to explore Cornerstone Rheumatology. So with that, I wish everybody a good afternoon and thank you for joining us. Bye-bye.